Susan Muirhead here at PKD Charity. It's myself that's been emailing you with links, etc. for tonight. You may have come across me at a previous event or perhaps on our helpline. I'm also joined by my colleague, the charity CEO, Alison Taylor. Hi Alison, thanks for joining us tonight. But most importantly, our stars of the show, so to speak. We're joined tonight by Professor Manish Sinha, a consultant nephrologist from Evelina Hospital. Hi, Manish. And joining him tonight, and I'll say we might have the troublesome. I think we've got the young upstart as well tonight. We've got Dr. Matko Marlais, again, a consultant nephrologist. Gosh, we were just having some fun behind the scenes there. But certainly it's great to have two of the leading consultants in the UK join us. I've got to always give the medical disclaimer, no matter who I have on the call. Myself and Alison aren't medically trained, and obviously those who are, Matko and Manish, do not have access to your full records, so it is for information purposes only tonight's meeting. We cannot give you individual medical guidance and advice. If there is anything that's discussed that's medically, please, before you make any changes to your own families, medications, concerns that you have, etc., speak to your own pharmacist, your GP, or your consultant. And we cannot promote any brands and treatments as such. It's just that little disclaimer that we have to do. More and more of us are familiar with Zoom, but we never ever make the assumption. I know my husband would be all fingers and thumbs. He's fine if he's got a touchscreen device in front of him, but if you give him a keyboard, he's very unsure what to do and wouldn't have a clue in a Zoom call. If you want to pop a question into the chat facility, if you hover along your screen, you will find what looks like a little chat icon. It's a little speech bubble. You can type something in there and we can ask that anonymously on your behalf. There's reactions, so you can give us a thumbs up, thumbs down. If you wanted, you could also raise your hand. And if you were feeling brave, you could come live, unmuted, and ask your question directly. We do ask that you keep your questions to the end of the presentations. For your own anonymity, please keep your video off during the presentation. If there's any background, the video will click round to yourself. So so you remain anonymous, it would be great if you could do that. If you have any questions or concerns, we're always here for you. On your screen at the moment, you will see our info@pkdcharity.org.uk email address. That email address is published on our website and available to you all if you have any questions or queries that you want to follow up with a member of staff at a later date. What I'd like to do is just hand over to the guest speakers that you're here to hear from tonight. So Manish, can I ask you now to screen share? I will just stop.
Thanks, Susan. I'll just change over 10 seconds. And just let me know if you can hear me okay, and if this is coming up as a presentation.
Everything's perfectly, and that's you in full slideshow mode there. Thank you.
Fantastic. So good evening, everybody, and it's really lovely to be here. I think Matko and I were here a couple of years ago last, and so it's really nice to have this webinar again. And it's an opportunity for us to just have a brief discussion about ADPKD in children and young people, and just update you about some of the activities that are ongoing in the clinical and research fold in the UK. Very briefly, that's not the focus of what we're doing. Summarize and then really open up for what we are meeting here today is to go through questions you may have and just answer any queries. And as Susan pointed out earlier, please do put your questions, and if they come later, please put them in to us and we can answer them later for you. So how do we get ADPKD? And this is, I'm sure, very well known to you, but this cartoon essentially shows that there is a 1 in 2 chance given the genetic sort of change and the transmission, it is 1 in 2 with each pregnancy of having a child with polycystic kidney disease if one of the parents has the condition. And depending on what population studies you read, it's a very common gene change which is there in our populations, between 1 in every 1,000 to 1 in 3,000. And for children, certainly the two main genes which are involved are PKD1 and PKD2. PKD1 gene is dominant, 85%, is more severe in its presentation, so younger age, when you're in 40s and 50s, a higher chance of having kidney failure as opposed to PKD2. There are a few other genes that have been identified, but they almost never present with clinical problems during early childhood or during childhood. So this should read as 1 in 2 children would be affected with each pregnancy. There's a 50% chance is what I mean to say here, as opposed to half of children. I'm sorry for the text. And the diagnosis on the clinical fold usually is made by seeing cysts on a kidney ultrasound scan. And if you look at some of the data which shows what happens in the clinical field across various countries, the most common way that this is diagnosed is an incidental finding, or there's a family history and there's been parental sort of concern. And that has been increasing in terms of the what we are seeing across, certainly in certain parts of Europe. And gene testing, which was quite rare in the past and usually done when there was no family history or it was a very early presentation, that has increased over the years, and I'm sure Matko will talk a little bit more about it later in this slide set. I just wanted to talk a little bit about how does polycystic kidneys cause chronic kidney failure, and this is just really a schematic, a cartoon of the central sort of unit of a kidney. This is a filter, which we call a nephron, which has got a glomerulus. So this is the ball here of blood tubes which bring the blood comes in, it's cleaned, and it produces urine. Most of it is water, and then there are lots of other sort of waste products which go through these different parts of this structure. And if you were to sort of cut across it and look down under the microscope, it may look like this. So different parts of the different filtering units show these gray and white sort of circles, as you can see. And the kidney, each kidney has about 1 million nephrons, and you know, these are constantly making urine. And what happens is that if you have the gene change which is causing the polycystic kidney disease, then it programs the kidney in a way that it produces these cysts in any part of these collecting systems. These are these tubules we call, and they are programmed to develop and grow, and as they grow, they destroy the structures near them and start occupying more and more of what is normal kidney, such that over time, and this time being not days and months, this is years and decades, you see reduction in the normal kidney, and therefore the ability of these kidneys to produce, to function as normal reduces. And this is again shown here as a cartoon. So on the line where, I hope you can see my mouse, where it's on the x-axis, we have put the age in decades, and the blue line or similar color is showing us the change in blood pressure. So the number of individuals at that age with polycystic kidneys who have hypertension sort of keeps increasing as you get older. But certainly for the young patients, so certainly children, so all children under 10, you can see here most children, those under 20, but also some young adults. the kidney function remains very well preserved, and that's because there's a lot more normal kidney tissue. But so the predominant problem seems to be with high blood pressure, and then as you get older, as we all know, more and more cysts develop, and the kidney function reduces. And so this is an important thing that we are very keen to address during childhood, certainly, and for young adults and adolescents. And if you look at the other clinical problems, I've shown them in two different colors. The blue ones perhaps happen a little more than the ones which are shown in different color, and certainly the ones in black font are not seen as often, certainly in the in the patient population we are looking at. So urinary tract infections, pain, sometimes passing more urine, sometimes visible blood in the urine, can be sort of one of the presenting reasons why children may present and then have an ultrasound scan of the kidney done. Or sometimes if they, for some reason or the other, have some injury, which has caused them to present with one of those findings. But most of the other symptoms and signs that I've shown here are not often seen during childhood, but well described and known in adults with this condition. So they don't have kidney symptoms, most children, and therefore, it is something which certainly for the high blood pressure side of things and some other aspects, we do have to keep an eye on them regularly. So at this point, I'm going to hand over to Matko, and I'll move the slide as you asked me to, Matko. Thank you.
Thank you very much, Manish, and thank you again to the PKD Charity for giving us this opportunity to speak. I'm going to talk a little bit about how we diagnose ADPKD in children and use the experience of what we see in our clinical practice to give you a range of different ways in which we find children with this condition. So most of the children I see at the moment in the clinic are still diagnosed what we call incidentally, but that basically means by accident. So there wasn't necessarily an expectation of finding the condition. Some cases will present to us before birth, and typically before birth on the routine pregnancy scans, we wouldn't see cysts, interestingly, unless we do the scans late in the pregnancy. Typically, the kidneys just look bright in some babies before they're born, and that can lead us down a path of investigating. But most cases won't be diagnosed before the birth, rather they'll have cysts detected during childhood. And so often children will have an ultrasound scan done for lots of different reasons. They might have had an injury, they might have some pain in their tummy, and when they do the scan, they'll also find that there are some cysts there, and that leads us down a path of investigation. And so, Manish, if you'll kindly move to the next slide, I'll take us through a little schematic, which I think is quite helpful to go through that. So these slides are a bit busy, but these are helpful schematics from the clinical guideline, which was published internationally earlier this year, because it shows you really what we're doing as doctors and clinical teams in our head when we see children with these conditions. So if we have a child who's found to have a kidney cyst, so these are often children who wouldn't have a family history of this problem, so they come to us with something found on a scan, we go down this route depending on what we see. If a child just has one cyst in their kidney, nobody else in the family is affected, then typically we would observe them. Although single cysts in children are uncommon, they're quite common in adults, and so as children get older, we do sometimes see children with just one cyst, so we would just observe those cases. And then in these other cases, here on the left, we have kidneys that are big or bright before the birth, or children who have a scan and are found to have several kidney cysts, multiple kidney cysts. We'd go down the route of looking into them based on whether they have a family history. So in those who have a family history of the condition, if you have bright kidneys before birth, or if you have kidney cysts in childhood, you almost certainly have a diagnosis of ADPKD. And typically that would be all that we would require. And then we would go down a route of managing that, which Manish will talk to you more about later. If there's no family history of ADPKD, but we find that a child has cysts, and particularly multiple cysts or problems before the birth, then we would typically go and ask for parents or grandparents, depending on age, to be screened. Because some parents, particularly young parents, may have cysts in their kidneys and just not know about it. And then dependent on that, we might decide to go down a further route of genetic testing. And I'll talk a little bit more about that in the coming slides. So that's really a very quick overview of what we do in the clinic when we find a child presents to us with cysts in their kidneys, and we didn't know that there was any risk of that beforehand. So if we just move on to the next slide now. The other situation that I think all of us are seeing more and more commonly in our clinical practice is families and children themselves sometimes asking for testing if they know they have a risk of ADPKD. So we've already heard that many people, by virtue of their family history, will have a 1 in 2 risk of having this condition. And lots of families understandably want to know the information for their child. So quite often in clinic, I'll be asked, should I test my child for ADPKD? Now, historically, there was a view by many doctors, and there's a view that's still held by some doctors, including some pediatricians, adult nephrologists, general practitioners, that we shouldn't test for ADPKD in children. And that view is generally because it was thought to be a disease which didn't affect children. We've probably changed in our thinking on this, and now we take more of a partnership approach and discuss with families the pros and cons of testing so that families can make an informed decision that's right for them, rather than us as doctors and healthcare teams telling you as the family what's right for you. It's about a shared partnership decision making. But it's important for families to be aware of the fact that the tests we have are not perfect tests, and there are downsides to both tests, and the nuance of which we can certainly talk through. And it's important, if you are considering this, to speak to the clinical team treating you. So if we just move on to the next slide, this is information which is taken from the information on the PKD Charity website and slightly adapted. But I think it gives a really sort of helpful balance of some of the positive aspects of testing and some of the negative aspects. So this is by no means comprehensive, and there'll be different situations for different families. But it just gives you an overview of how some aspects of testing could be helpful for you and your family. So you can see here on the left, there are some positive aspects of testing, including the fact that the test will often give a clear answer, which will reduce uncertainty. And for many families, knowing that a child doesn't have ADPKD can be a real relief and reduces future worries. It also means that we can target discussions and conversations about new treatments in the future and research studies. But negative aspects of testing include that sometimes testing is unable to give us a clear answer, and there are different reasons why that might be the case. And also some children may regret knowing that they have a condition. There is a view that children and young people should be allowed to wait until they're around 16 or able to make the decision themselves about whether they proceed to testing. And there are also potentially other implications depending on what is already known about the family. And these situations with things like insurance policies clearly change over time. So it's very difficult to give information in a market that's constantly changing. So next slide, please, Manish. So I'll just take us through another couple of diagrams now, which really show you what we're thinking as clinicians when someone comes to us and says, I'd like to consider testing for my child because I know they have a 1 in 2 risk of having the condition. So we would have, as I've said, a shared decision-making discussion about the pros and cons of testing and with the family. And certainly in older children, we would want to very much include the child in that conversation. On the right, we can see that some people decide after discussion that they don't wish to diagnose. And at that point, we'll continue managing, and the next slide will show you what we do in terms of the clinical management. And then we talk about the different types of testing that we can do. So ultrasound testing is a very good test to do. It's non-invasive, doesn't involve any radiation, so there's no harm from an ultrasound scan. And if it shows cysts in a child who has a family history, then that essentially confirms the diagnosis of the condition. But the problem with ultrasound scanning is if there are no cysts, then in some children, that's because the cysts haven't developed yet or haven't been seen. And so it's difficult to say for certain that a child doesn't have the condition if an ultrasound scan is done, particularly in early childhood. And then in terms of the genetic testing, this is a really complicated area, not one I can do justice to in the time we have here. But essentially, there are a proportion of people and families who clearly have the disease, ADPKD, but current genetic testing doesn't yet detect what we call confirmed genetic changes or variants. And that sometimes means that there can be a frustrating process of us saying as doctors to families, we think you have the disease, but not being able to find a mutation. And that can make it difficult to go and do testing on children if we don't have confirmation. And this is also a space that's really rapidly changing. And the expansion of availability of genetic testing is really good. But it does mean that we're now coming up against challenges over whether we should be doing genetic testing more than we used to. And I think this is a space which will change over the next 5 years. And so we might be offering testing for things now that we aren't offering in 3 to 5 years. And that will depend a little bit on NHS policy as well. So any further conversations about that should certainly be tailored to your individual family situation and your child. And then just moving on to the last slide, I think it's really important for families to know that if you decide not to test your child for ADPKD, or if the child decides not to test themselves, that's completely fine. That's a perfectly legitimate decision. All we would say is that we would recommend that we follow up as though your child has ADPKD, because there's a 50% risk of it, and that would be with blood pressure monitoring, to make sure that if there is a problem, we're not missing it. That doesn't mean that we then need to diagnose them, but obviously if we do find high blood pressure, then that might lead us down a path of diagnosis. But this is generally what we'd recommend. So I'm going to stop there, and I'll pass back to Manish for the final part of the talk.
Thanks, Matko. That was really helpful, and I'm sure we'll take questions and discuss this further after this. So just to go on to just give a little bit of an overview of what we do at the center where I work at the Evelina London Children's Hospital. We have a specialized children's ADPKD clinic, and the key focus there is to discuss the clinical issues with families and just really inform them about some of the content that we're discussing here. And with a focus on looking at the blood pressure, we do that in a very tailored way. We do it in a very precise way. And we also look for any evidence, obviously, of the child having polycystic kidneys, usually with an ultrasound study, and increasingly with genetics, with 60 to 70% of the children we see in our clinics now having genetic studies done. Now that it is offered on the NHS routinely. We also, a lot of what we do is signpost our families to the PKD Charity, because this is a very, very good resource for informing about, information about the condition. And at different stages within one condition, sometimes children are not really keen to go on it, but when they're young, but adolescents sometimes might want to, and certainly parents I've spoken to over the years do go to it from time to time and sometimes take part in the various sort of groups as well. We spend a lot of time doing discussions around the diagnosis, some specific clinical issues, sports. We talk about lifestyle advice. We talk about preventative measures, which are also helpful in sort of reducing the risks of increased stress on the kidney, good drinking lots of fluid, avoiding non-steroidal anti-inflammatory, and all generally having a healthy lifestyle. One of the other focuses of our clinical service is to transition and transfer the children in an appropriate way to the correct sort of adult service, varying from, because during childhood, as I alluded to before, kidney function is usually very, very good, if not completely normal. But there's a concern that might change over the coming years. And so what we really want to make sure is that the child often referred to the same nephrologist as is known to the parent. So the parent's nephrologist and the child, they'll usually go to the same physician. And because their kidney function is very good, then there's just whatever the plan made by the adult nephrologist is really very helpful. And then in a partnership with the general practitioner and the patient, now an adult, it has a much higher chance of working, and the child and the young person remaining under appropriate medical reviews. particularly important for girls as they become young women and are thinking of having families, be able to get them the right sort of advice and discussions at the right time. We have also, over the years, been working very closely with the PKD Charity and colleagues, adult nephrology, and discussing the research agenda within the UK. And these are some of the key research questions that have been considered and been put up by patients, by the professionals, and these were the top 10 questions which were published some years ago. And importantly, we had 3 of these which are very relevant to children and young people, and focus of research hopefully coming years. There is a plug here. We have a research study going on at the moment, which is the focus of that is to try and understand what is the risk of having high blood pressure if, as a young person, you have a parent who has the condition, but you have, as a young person, never been evaluated before. So what we are offering in this study is an opportunity to be tested. We will look at your blood pressure. We will look at your complete clinical sort of state, but also diagnose any high blood pressure, but also look at the genetics and involvement of the kidneys with any cysts with using MRI. And so this study has recently started, and we're delighted. We've already got the first few patients come through, and it's really an advertisement. And I know, thank you, Susan Nansen, for hosting the study on the PKD Charity website. And we hope to answer this really important question, whether high blood pressure is an issue in undiagnosed young people who have a risk of polycystic kidney disease, so that we can get some more meat on the advice, which is, as Matko was saying, we have slowly started moving away to saying ADPKD is not a condition without problems for young people. So in conclusion, just for this, I think we do recognize that in the UK, care of children with polycystic kidney disease and those at risk of polycystic kidney disease remains variable, and it does vary because of differences in opinion and understanding about the condition. But increasingly, there is a recognition that it's not just an adult disease, but although most children are asymptomatic, high blood pressure is one of the sort of key concerns. And it's easy to once you diagnose, it's very easy to treat high blood pressure in children. And children, young people are very receptive to positive changes in their health and lifestyle to address the issue. So we do think it's a really important question and important issue to consider. There have been, as we were alluding, more and more genetic diagnosis being now made, primarily because of the availability of this way of testing. So this WGS stands for a way of testing for genes using gene panels, which is very efficient in terms of the costs for it, but it does take about a year before results are available. And it's a really rewarding field. I think both of us and a number of my colleagues who work in this field find it really very rewarding to work with families with ADPKD. Children, young people, this is one of my learning points, always open to learning, and you always come away from clinics with a smile because of something new you've learned. And I really do believe that there is a therapeutic window here in the life course of an individual with ADPKD. And I think, the young patients, not younger, the young patients and young adolescents, they are really, really receptive to learning and understanding about their condition. But it has to be done, as we said, in a very shared partnership way, so that it fits in with what the family and the young person wants. So I think that was my last slide. I will hand this back to Susan Allison and stop sharing at this point, if that's okay. Thank you.
Thank you both for a lovely presentation. I'm just watching as a little flurry of questions coming in there, and thank you everyone for being so patient and not popping anything into the chat till we were ready. So I'm sure that Alison's going over them with her eagle eyes. And I don't know if you did all notice in the chat when Manish mentioned a higher PKD study, which some of you may be interested in finding out a little bit more. I had popped in the chat that tomorrow I'll circulate a link with that, and you can have a little look about the research project on our website. And if it was something of interest or you had further questions, you'll be able to connect with an appropriate person. So I'll certainly get that shared with it just now. See, there's a couple of questions coming through about blood pressure. So we might as well move to that first of all, because I know it's something that was asked in advance. If high blood pressure is the early warning sign of PKD, when and how do I get my child's blood pressure monitored or checked? Or can I just do it at home with an adult blood pressure meter?
So I'll jump into trying to answer this one.
Yeah.
So it would be useful to know how old your child is, but generally speaking, if the child is very young, so certainly under 5, the likelihood of having very high blood pressure is very, very small. So I just initially want to reassure people that this is not common, and it's very unusual to have very young children having high blood pressure. The difficult thing is, like all these things, until we measure it, we won't know. And because of the differences in the size of our young children and children in general, we are talking, it's important to measure it using the right machine and equipment. And so using a blood pressure machine, which is generally in the house because of mom or dad, would not be the right way of measuring it. So if there is a concern and you want to know about the blood pressure, the best place to go, as we are in the UK, we would go to a GP. For very young children, I think most general practitioners would not always have a right size blood pressure instrument. But there are some general practitioners, some colleagues who do have that. So I think I would still say going to them, but they would then make the referral to the next level of care, which would be the general pediatrician, where that would be checked appropriately.
Yeah, and I hopefully that answers someone in the chat as well, because they were asking at what age do you typically see hypertension start in childhood? And I'm trying to reflect back to the slide you showed with the chart where the line was drawn through it, if you can say the average ages, etc., where you would usually see that.
Yeah, so I think from our clinic, if you look at the last 200 children we've seen in our clinic, the average age is about 10 years. Mm-hmm. Where we have the hypertensive child 10 to 12 years. So that means there are some children who are younger and some older, but I think you have a higher chance of having higher blood pressure the older you are as a young person. So adolescence is going to be much higher chance. But it's easily diagnosed. So, if your blood pressure is found to be completely normal as a young person, let's say at 8, then, the chances of it becoming high, as in becoming abnormal, is it only will rise very, very slowly. So it's not suddenly going to change. So if you've checked it once, you just have to recheck it in a year or 2 years' time. And that's really important. You just need one check and you don't need to then worry about checking it very, very frequently. I hope that helps.
That's lovely, because I see someone else has popped into the chat. Again, what age should we do it and what readings should they be? And they've given the ages of their own children there at 6 and 8. So I'm assuming there should be target ranges for a 6-year-old and an 8-year-old that any health professional giving it a blood pressure check would be able to compare it against.
That's absolutely right. So I think the general advice would be a child at any age should have their blood pressure checked at least once. And, it's the health professionals who are looking after children will have normal data to say whether this is in the right range or not.
That's super. Alison, is there something caught your eye there in the chat, just to come away from blood pressure from a moment?
Yeah, somebody's said that they have ADPKD and have a son who's aged 7. How would I find out whether I have PKD1 or PKD2? And also, with him being at risk, do we need to take precautions with him playing rugby or boxing, sort of protecting his kidneys in any way?
Thank you for the question. I'll start with this one. So the only way you would find out for certain which gene is affected is by doing genetic testing. There's an increasing amount of discovery of other genes that are causing ADPKD, but the vast majority, as Manish said, are PKD1 and 2. The only way you would know for certain is by doing genetic testing. And I can see there was another question in the chat about whether some a sort of kidney function later in life that's preserved, meaning it's PKD2. Well, it's not necessarily so. So typically PKD2 has a slightly milder course with later kidney problems, but that's obviously an average, and individual people and children don't necessarily always follow the textbook. So it's not possible to know with kidney functional scans whether it's PKD1 or 2. The only way to know that is with genetic testing. So with regard to the protections, I think one of the difficulties here is that you'll probably get different answers from different people that you speak to. And that's so my approach, and I'll be very interested to see if Manish agrees with that, is that it's not our job as healthcare professionals to tell you how to live your lives effectively. It's about knowing which risks we feel are inappropriate for people to take. So I personally wouldn't do certain extreme sports. I don't have any health issues, but that's a choice that I make for my life. And so if rugby is really important to your child, then doing it is probably of more value to their life than the theoretical risk of having an injury and doing some damage. Now, that probably sounds a bit unhelpful, and some parents often want me to tell their children in clinic, you can't do this because it's something that they don't want to do, like, extreme BMX riding. But I think it's just about taking sensible precautions and having a sensible approach to things. So if you are doing BMX, for example, wear some of the protection pads, and whether you've got kidney disease or not, because you could break your spine doing that. So I don't think, my view is that we as healthcare professionals shouldn't tell you how to live your lives. Really, it's about giving you the information you need to make informed choices. So we can tell you, for example, how many cysts your child has, or if they've got a very big cyst that might cause some symptoms, we can talk to you about that. But generally, we wouldn't advise sort of blanket rules of don't do this or don't do that. But I think, again, every healthcare professional has a slightly different approach to that. So keen to hear what Manish thinks.
Thanks, Matko. So yeah, I would agree with that. I mean, I think, in practical terms, thinking about the last few children where this question has come up, you're talking about a young lady who was very interested in trampolining at a very serious level, was taking up gymnastics at a very good level. Somebody was interested in kickboxing, somebody wants to go horse riding. So, at that sort of age where they were 9 to 12, when we were having those questions and discussing it, we tried to inform the young person in a way, because they were very keen to understand why they should change what they were doing. And what we did was we usually don't perform repeat ultrasound scans of the kidneys once we know the diagnosis, because it's not helpful. But in these situations, we do. We repeat an ultrasound scan. We look for the specifics of what Matko was just referring to see what the cyst distribution is. Sometimes you can have large cysts which are on the periphery, and there's an increased risk of trauma to those cysts. And we can then highlight, we can show this to the young person, and we can highlight why we are concerned about that. And understanding that, usually does make them think about it a little bit more. Because it's very unlikely, I agree with Matko, if I just in clinic said to them, don't do this, that they are going to stop doing it. They want to understand why. And there's some perfectly good ways of trying to approach that, and that they do find helpful sometimes. So that's just sort of personalized approach a little bit, and just informing the young person certainly helps a little bit more.
And just a lovely topic that we can matching with just precautions there. It's what can we do in lifestyle to help young people?
So I guess, yeah, we'll probably both comment here. I'll start. So the general advice that I give to my patients that I look after with this condition is to do all the things that is sensible to do for people in general. So I would advise against smoking for our teenagers. I would advise against all the things that you hear in the general press. And I know these days there's lots of fake news. I hear that paracetamol's off the cards today. But generally, we would advise good sort of general medical advice for a healthy lifestyle. There are some specific things that people do, and quite a lot of people talk about whether drinking lots and almost drinking too much is beneficial in this condition. And there is some work looking into that. But again, what I tend to advise is to make sure that our children and young people are well hydrated and that they avoid any episodes of dehydration. So particularly if it's really hot in summer, making sure that they're drinking fluid liberally. Generally, I don't advise over drinking. That's something that I do get asked about because there is a theoretical benefit for over drinking, but that's not been proven convincingly. And also, we would advise things like avoiding things that can do harm to the kidney. I think, Manish, in your talk, you already talked about avoiding certain drugs, such as non-steroidal anti-inflammatory drugs, so things like ibuprofen, to try and protect the kidneys, and also avoiding excess salt in the diet. That's particularly important for people who have got high blood pressure, but even if you don't, avoiding excess salt is generally a good, healthy thing to do. I'll stop there and let Manish come in.
Yeah, no, sorry, my mouse wasn't working. So yeah, no, I think you've covered everything. I just really giving them advice about, really thinking about a healthier lifestyle. So, exercise and avoiding excess unhealthy weight. And for girls specifically, some specific advice about oral contraceptive pills when they are older. So that's, not necessarily lifestyle, but, these are some general sort of advice which we would give to all young people and then tailor it depending on their specific sort of needs as they grow older. Yeah.
And something that would be appropriate to mention just now, someone's popped into the chat about NSAIDs, so non-steroidal anti-inflammatory drugs. Can we do a little recap on those, the ifs, the buts, and the maybes?
So those are just drugs which, they are known to cause increased stress on the kidney, essentially, and we sort of avoid them if you have an underlying kidney problem. So we are talking about, as Matko said, ibuprofen. So these are painkillers generally taken by, they're available over the counter, and naproxen, ibuprofen, and there are lots of other different ones, stronger and stronger. And you can, for young children, if you have temperatures, you can use these sort of medications, but again, we say just give the right dose of paracetamol, and that usually sorts out problems with temperatures, but also pain. And you can then get away from having to use them. So the idea is that these medications increase the risk of having an increased amount of stress when you are unwell, so causing acute kidney injury potentially, and we're just trying to reduce that. So that's one of the reasons why we say not to have non-steroidal NSAIDs.
Thank you so much. Alison, something caught your eye? Yeah.
Somebody's asked, and I think it's quite good, and it'll also educate me. So somebody's asked, obviously, in children who have high blood pressure, is the worry about that keeping it down, you're trying to slow cyst growth over the longer term, or are there other benefits of controlling blood pressure? She's trying to weigh up whether the monitoring blood pressure and keeping that down is worth the extra stress and worrying whether it's high or not, I think. So why are we trying to keep the blood pressure down?
So I think the main reason, so there were two very, very good studies in adults which showed, they're called the Tempo 1, Tempo 2 trials, I think, which were many years ago. But what they showed really well was that irrespective of what level of kidney function you have. So, whether your kidney function is working well or not so well. And they divided that in those two studies as having less than 50% kidney working or more than 50% working. And what they were able to show that the individuals, and they all had ADPKD, the individuals who had higher blood pressures in both those studies had much faster decline. So they had worse kidney outcomes. Their kidney failure, so the need for either dialysis or new kidney, was earlier if your blood pressure was higher. So high blood pressure, to answer specifically, does not increase the rate of increase in cysts growth. So it doesn't affect cyst growth. But for all kidney conditions, if you have high blood pressure, it does insult the kidney such that increases the stress and the kidney function declines much more rapidly. So the way to think about it is in polycystic kidney disease, control of blood pressure helps in reducing the blood pressure effects in general, which can happen to anybody who has kidney problems, but also generally the rest of the body as well. So it affects, it helps in reducing the risk of having problems with high blood pressure, but also the kidney outcomes are better. So the same kidney function lasts longer. So specifically for children, the same studies have not been done because they would take decades to do. So, but just extending some similar sense, common sense to the what has happened to the adults, we feel it is important that the blood pressure should be improved. And that's what we do for any other condition. When children have poor kidney function, we always try to optimize their blood pressure and in fact keep it at a lower level just because it is much better for kidney function. I probably have said a lot. I don't know if that was confusing or helpful.
No, and I think there's another worried mum. You're getting a thumbs up there from, I think, the lady who'd asked the question for that one. There's a worried mum in the audience as well. Our son, age 12, has just recorded high blood pressure. We've just been to the GP and now we're keen to get advice on the next steps and timing suggested. And Dad is known to have PKD type 1. So the core thing is we've got our first ever blood pressure reading or a recent one with a high blood pressure. What would the next step be?
So the most important thing is not to worry too much about it because, if you can imagine, if you had a blood pressure done just once, the chances are, it could be a 50-50 up or down, and that's what you've got. So even to diagnose hypertension, we would usually want to recheck the blood pressure at least 2 or 3 times on separate occasions. So the most important thing is to just recheck it again using the right equipment. And so if the blood pressure is high, and obviously I'm presuming the child is well in themselves and is otherwise got no other concerns, then if it's just a check, all they need to do is just have it rechecked. And if the GP is then concerned that the blood pressure is still high, then they will make a referral. As you would expect, most of us don't enjoy going to a doctor, to the GP surgery or hospital. These are places which can cause us anxiety, particularly so if you're a young person. And so quite often the first readings when we get of when the blood pressure is measured in this environment, that can be what we call in medical parlance a white coat effect. So that's something which is caused anxiety and made your blood pressure go high. So it just needs rechecking, and it probably will be fine.
Mm-hmm. And just on the subject of testing, someone's commented, other than the mental health issues and assuming a general healthy lifestyle, is there any real benefit of monitoring anything other than blood pressure?
Matko?
I guess we wouldn't normally advise it because the chances of a child having reduced kidney function on blood tests or significant protein in the urine is very low. And high blood pressure tends to be the main finding we see in only a small proportion of children with this condition, but there is a definite effect there. And so we expect that you wouldn't miss a problem on blood tests if you're monitoring the blood pressure. Now, clearly, nothing's 100%, but generally that's a very reasonable approach to take, is to keep monitoring the blood pressure. And then when the individual becomes an adult, they can obviously make their own choices about testing and going from there.
Thank you. And a lovely one is something that comes up often in the community, and it's great that someone's felt they could join tonight and ask this question. What is your advice for couples considering starting a family? I have PKD, but genetic testing did not find a gene, so we're unable to carry out any embryo screening for the gene.
I think that's a really difficult position to be in. I'm sorry you're in that position. That's a really challenging position to be in. Obviously, decisions about that are very personal, very emotive, and certainly not for us to tell you how you should proceed. What we would say is that during pregnancy, it would be worth making sure that the team that you're seeing are aware of that, and potentially getting a detailed scan in the second trimester if you'd like to have that information. But I don't think we can tell you, without the genetic knowledge, unfortunately, you obviously don't have anything that you can go on with current technology.
Thank you for such an honest answer. It's a difficult position to be in.
Can I
Alison,
just ask
yeah.
something to clear something up for someone? Somebody's asked, can ADPKD skip a generation and be passed by a grandparent to a grandchild? No, I don't think so.
No. So it's interesting. I mean, that this question does come up in that, we have over the years diagnosed a number of parents who have first found out that they have the condition because their child has been diagnosed to have the condition. So we find cysts on the child. We then ask the parents if they know that if they have cysts on their kidneys. They've never had an ultrasound scan done, but there is family history with one of the grandparents of the child to have polycystic kidneys, and we then end up diagnosing it for the parent, which is great for that parent, we feel, as pediatricians, because it helps to make sure that they have better health and their health needs are met as well.
I'm just scrolling through because I noticed a lovely question. It's something that many people in the audience, we watch our children grow up, and as PKD parents, we know that our own health declines. How do we talk about the decline due to PKD to our children?
So I'll start off initially. I can only give anecdotes, I think.
Yeah.
I think, I truly believe the parents know their child the best. So, a lot of that is guided by parents themselves. I have two daughters, and, they're both individuals, and there were differences in the way we approached the same topic as they were growing older. But one thing was very, very obvious, and I think, a lot of parents tell us this, and young people tell us, children are very aware from, I would say 9, 10 years of age, 8, 9, 10, when they are very aware of things happening in the family, parents having appointments, going to hospital, grandparents, having similar sort of things. These conversations come up. So it's not that they don't know that there is something going on with their parent, specifically about the kidney condition potentially, or the need for hospital appointments. But children have this amazing talent as well. They're very protective of their parents. So if they know that this might cause some concern or anxiety to their parents, they sometimes will not talk about these things in front of them. And that is, so if this is something, your child is already known to a health professional, that is one place to sort of bring that up and have a conversation, and that can be done in a very sensible way. But, I think a lot of children are already aware about it, and you just, you'll know probably the best time to sort of consider it. I don't know, Matko, if you've got some additional thoughts or comments on it.
No, I mean, I think you've covered it really nicely, and I'd say actually, you know, talk to colleagues in the PKD charity and other families, and because you know, well, as healthcare professionals, I don't think we will know it as well as you who have lived experience of this condition. We can only tell you anecdotes of what we've seen, as Manish has said.
As Manish was chatting there, I'm reflecting, first and foremost, I'm a PKD wife. My husband has PKD, and I remember my son thinking back, he was maybe about 7 or 8, and asking his daddy, what are you taking your tablets for? He was so used to daddy at tea time or in the morning taking his medications, which were blood pressure control. And the answer was, if I don't take them, I might go boom. So after that, there were daddy's exploding tablets. Now, if the person asking that has any questions, I'm happy to answer it off the chat here. If they want to phone the helpline. They're also asking about chatting to children about dialysis. There's some wonderful books available. H for hemodialysis, T for transplant, and there's another one in the range. If you want to reach out to info@PKD Charity with that question, I'll be able to respond to you directly with a personalised email. But certainly there's some lovely books depending on the age of children. They're for young readers, I would say maybe from about 6 till 10, thereabouts, but they're lovely little paperback books that go through dialysis and transplant for children. And Alison, has something caught your eye? Because I'm aware we're into the closing minutes, and I think there's 4 new messages appeared, but I haven't had a chance to look at them.
Yes, they're coming in thick and fast now, as they always do. So we will try our hardest, but I don't think we're going to get through all of them. I think one that's come up, and there's a couple that are the same, saying thank you for the talk. What kind of diet is considered best for somebody at risk of PKD? There are lots of videos online, but some advice would be useful.
I mean, I think for children and young people, we would generally want them to follow a normal diet, and clearly children, you know, there's information about having low protein diets and things. If you're an adult with kidney disease, children need protein for growth, so we would generally advise a normal diet for a child. If a young person has raised blood pressure, then we might advise a low salt diet. And as I've already said, I would avoid excess salt in general. We all generally have too much salt in a Western diet anyway. But I would say for a child, particularly a young child, a normal diet, partly also so that they don't feel different to their children and peers and friends, and because we equally want them to have as normal as possible an experience of childhood.
Yeah, I agree. I think we should keep it as healthy and normal as possible for them, including having whatever treats they want to from time to time, which is all very sensible. Yeah.
That is absolutely super. I think that is the ideal opportunity to say our thank you. You have both been fabulous, and I appreciate you both giving up your time so freely to prepare the slides. It's not just your time tonight. It's really, really appreciated.